This is also entitled Special Topics in Antifungal Therapy, but it's also, as you'll notice, also known as the Greek section of this presentation. We're going to be led off by Dimitrios Kontoyiannis, and then Mihalis Leonikis at NIH is going to join us virtually, and then I'll lead the facilitated discussion, after which we'll break for lunch. So Dimitrios Kontoyiannis from MD Anderson is going to give the first talk. It's new cancer agents, immunosuppressives, and the impact on invasive fungal infection.
Okay, good morning. Thank you for inviting me, and it's a pleasure to be here. So what I'm going to do in the following 20 minutes or so is to give a very quick overview of a very complex and rapidly changing field, which is the new oncology ecosystem, and maybe some thoughts of how that might influence fungal risk or the way we try to treat fungal infections. So we're going to talk about some examples of some good things in terms of decreasing fungal risk, some bad things or potentially bad things, and some ugly things in terms that this can be good and bad depending on the context. And I'm going to close with some questions that probably reflect a little bit to other talks and other discussions we have about the nuances of assessing responses and natural history of fungal disease in 2022. So this is a slide I like to show because it really, in a slide, recapitulates 50 years of development in the area of leukemia and transplant. It started with the pivotal studies in the 1960s by Freyreich and Bode, when it showed that people were dying from infections in the setting of neutropenia and bleeding. Bleeding was controlled by platelet transfusions with the Freyreich seminal work in the 60s, and then infection became a dominant cause of death in the early 60s. And back then the infections were due to Staphylococcus aureus. The introduction of anti-staphylococcal antibiotics really controlled this problem to a big degree. In the early 1970s, the big problem of cause of death in leukemia was gram-negative infections. People were dying typically of Pseudomonas sepsis. And then good antibiotics were introduced, third-generation cephalosporins and anti-Pseudomonas penicillins. And then around mid-1980s, late 1980s, Candida has become a cause of death, something we don't see anymore for a variety of reasons. Then a revolutionary drug, not only for Candida vaginitis, as Jack said to us, but also for systemic fungal disease, called fluconazole, was introduced in 1990 that really simplify to a lot of way treatment of Candida and make it much more palatable. And when I started my career in early 1990s, aspergillosis started becoming the problem, maybe occupying a biological vacuum of better treatment of bacterial infections and Candida, aspergillus. And then in the last 3 decades, we have dealt with increasingly complex epidemiology of fungal infections, the issues of resistance. And what I'm going to talk about today is the last 5 or 10 years when we have seen a revolution of new targeted therapies for hematologic malignancies, improvement in supportive care overall, and improvement in the way of treatment of allogeneic bone marrow transplantation. For bone marrow transplant, that has been also another success, started by pivotal experiments in Fred Hutchinson Center in 1980s, and then you have seen a tremendous improvement, and the needle has been moved to the right with better procedures, better supportive care, expanded donor pool, less conditioning, dependent mortality, etc. And I think now the holy grail of transplantation is, can you find this sweet spot between having graft versus leukemia effect without having graft versus host disease? Can you separate these two immunologic effects? Can you have biomarkers to predict outcomes, an increasing role of microbiome or microbiome? And Dr. Ghanom is going to talk about it later on, about predicting outcomes in the setting of different diseases, including transplant. So when I was still a postdoc in Boston area in 1990s, the Weinberg lab that was next to us at the Whitehead Institute has published a very influential paper in Cell. You can see on the left part of your slide about how we understand cancer in late 1990s, and had to do with evasion of apoptosis, sustained angiogenesis, limitless replicative potential, tissue invasion, insensitivity to anti-growth agents, self-sufficiency to growth signals, etc. And now the field has moved in a decent way with better understanding of cancer, and the same group, Hanakan and Weinberg, published how much has been gained in terms of knowledge about 10 years afterwards, when people talk about evasion of immune destruction, tumor-promoting inflammation, genome instability and mutation, and the regulated cellular energetics. So clearly the classic targets, I have a cancer cell, I kill it with big poisons, have been changed. And a part of the revolution has been the introduction of genomic medicine, genomic profiling, to profile both somatic and germline cells in cancer patients. This is one of the big studies that was published almost 10 years ago in New England Journal of Medicine that identify actionable mutations like the FLT3 mutation on NPMI mutations, and this really push a new revolution in industry about finding this magic bullet that is not a poison that can control tumor growth. And this has become big news very quickly, even in the lay press. This is a Time magazine cover that talk about the new era of small molecule kinase inhibitors that can control cancer. And probably this list is probably 100 names that we cannot even recognize, or even the Greeks cannot spell. And this is one of the profile in our leukemia service. In our leukemia service, to give you a sense of our operation, we have 130 inpatient leukemia at MD Anderson every day, hospitalized. About two-thirds of them are old, frail, elderly, with comorbidity, people you will never see in clinical trials. And then the leukemia doctors stratify these patients based on the degree of frailty and design, based on molecular profiling of these patients, to light regimens that really do not get a lot of toxicity, or more aggressive regimens. Like if you're 40 years old, no comorbidities, you have aggressive leukemia, you still go with the backbone of RSC daunorubicin plus something else. If you're 80 years old with a lot of comorbidity, you go to epigenetic agent plus something else based on profiling you have. So clearly much more complexity to the classic RSC daunorubicin, the 7 and 3 regimen that has been the backbone, the workhorse of remission reduction chemotherapy in leukemia for almost 40 years. And if you see the options, and probably this table is getting outdated by month, you can see the revolution of molecular targeted therapy in AML, lymphoid malignancies, big news, myeloma, extremely complex disease now with very complex regimens, and also all kinds of lymphomas. And you can see monoclonal antibodies, proteasome inhibitors, anti-apoptotic agents like venetoclax, etc., etc. So the physicians of today, or the pneumacology of today, is going to go to an era when he's going to try to understand fungal disease in its natural history in the context of what those drugs do to the immune system, or I'm going to make a point even to the fungus itself. And let me give you some very good example. This area is a obviously very expansive area. The good, the bad, and the ugly. The good is basically the introduction of epigenetic inhibitors, such as basically azacitidine in low-risk MDS, frail patients, typically very elderly patients who cannot tolerate heavy-duty chemotherapy. And this has not been a given for a long time. All these people were given high-dose chemotherapy and they had an early death due to toxicity. Now, most people with MDS go to a program with an epigenetic inhibitor plus minus venetoclax, and they don't get a lot of toxicity. And in this patient population, it's not for sure that you need to give antifungal prophylaxis, and the fungal risk is rather low. Then, an increasing population of diseases we did not think they are associated with fungal risk are the patients with lymphoid malignancies, chronic lymphoma, CLL, hairy cell leukemia to some degree. And here the revolution has been the introduction of molecular targeted therapy, such as Bruton kinase inhibitors. Those agents in a minority of patients, and we do not understand exactly who those patients are, they're typically less than 5%, can get down with some ugly early fungal infections, Cryptococcus, CNS aspergillosis, PJP, etc. Very early on in the introduction of ibrutinib, for example, descriptions of pneumocystis emerged. The very important paper from NIH by Maklionakis et al. Also documented a high rate of, very interestingly, CNS aspergillosis. We have been involved with John Perfect, and we described early series of early cryptococcosis in those patients, etc., etc. But I think it would be simplistic to say, I have a patient, he gets ibrutinib and he comes down with a fungal infection. If you see all these series, most of these people were heavily pretreated, so the net state of immunosuppression was kind of significant, and most of them got steroids. In a way, reminiscent to the old story of fludarabine, that when I started my career, when fludarabine, a lympholytic agent, got a lot of opportunistic infections in the setting of steroids. When we look in our experience at MD Anderson with almost 850 patients, 2.5% of them had proven fungal infections, typically pneumonias, most commonly aspergillus, but you could see other, fungi there. And the risk factors for fungal infections in our experience was monocytopenia and refractory underlying disease, with more than 3 lines of therapy being given for underlying disease. So, and the question comes now, and as I said before, that's going to be a niche area, a very interesting area, hard to study area, how to study those targeted therapy for malignant disease in terms of excess fungal risk, natural history of infection, prognostication of the infection, and treatments, as a lot of those drugs interact with adeneoplastic therapies. And I invite you to read this very nice review by Dr. Little in Journal of Fungi that gives a very nice overview of all this expansive area of infection. Now, moving to checkpoint inhibitors, you cannot talk about cancer chemotherapy in 2023 without going to the revolution of checkpoint inhibitors. That basically the concept that was, the subject of a Nobel Prize, one of them was Jim Allison in our center, was basically, can you remove the immunological break through the PD-L1 disengagement, basically, and then the immune system is awakens and attacks the tumor. It's a simplistic way to say it. Obviously, the autoregulation of the system is much more complex, and Dr. Wooster in our group in the afternoon will focus his talk in this area particularly. But as you can see here, every month there is a new checkpoint inhibitor being introduced, to the degree that there was a New England Journal of Medicine editorial called The Wild West of Checkpoint Inhibitors, because there is so much of it and so much unregulation how much those studies are those drugs are introduced and regulated. But you can see inhibitors against PD-L1, against PD-1, and CTL4. And if you go to a tertiary care cancer center, like my place, everybody seems to be on a checkpoint inhibitor-based chemotherapy. There was a science report that there were hundreds of clinical trials that incorporate a checkpoint inhibitor, typically for solid tumor, but increasingly so for leukemia. So checkpoint inhibitor is the hot molecule or the hot classes of molecules to be studied in the modern cancer ecosystem. And those drugs, although revolutionary in clinical mycology, come with their own price. Price being autoimmune side effects, immune-related side effects. And if you go to a morning report in a cancer hospital, one of the two cases we discuss is some kind of autoimmunity problem, renal, problem, pneumonitis, adrenalitis due to checkpoint inhibitors. All organs of the system can be the subject of attack of autoimmune, damage by checkpoint inhibitors. And what do you do in these patients? You give them corticosteroids and or TNF inhibitors such as infliximab. And this comes at a risk of superinfections, including fungal infections. And this is the best paper comes from Sloan Kettering by De Castillo et al. That really puts us at high risk, corticosteroids, infliximab, and you can see a fungal risk of about 3% in solid tumor. Solid tumors is not a group that you get a lot of opportunistic fungal infections. However, if you turn around and ask the questions, if I remove the immunological break and the T-cell exhaustion in chronic antigenic loads, such as chronic infection, is it a good thing or a bad thing for infectious disease? And we have written this review a couple of years ago that we try to make a point that in most cases, checkpoint inhibitors without the immunological consequences that you need to give corticosteroids is not a bad thing. Actually can augment immune responses. And if you go to the mycology field and ask the questions, what do I know about checkpoint inhibitors and immune responses, there is a surprisingly list of very good preclinical models that say that those agents enhance immune response. One of the best paper came in PNS from New York with histoplasma, but also studies have been shown in Candida, Coccidioides, Cryptococcus, Paracocci, Aspergillus fumigatus, etc. So we have tamed this double hit hypothesis, saying that if we're going to use checkpoint inhibitors in AML to control AML, maybe checkpoint inhibitors are going to be a good thing to decrease excess fungal risk for aspergillosis specifically, and maybe make the natural history of infection a little bit better. So we embarked in a series of studies a couple of years ago, and Sebastian is going to talk about it later on in the afternoon, when we gave in experimental model checkpoint inhibitors alone, no antifungal. In experimental causes of experimental models of aspergillosis. This was published in JID a couple of years ago. When we have found if we give the full oncological dosing of checkpoint inhibitor in the setting of a hyperacute infection with high antigenic load, you get prohibitory toxicity. If you go and attenuate the dose of checkpoint inhibitor, then you get surprising good response and good control by checkpoint inhibitor of aspergillosis based on mortality, protective cytokines, fungal burden, and histopathology. And if you compare or team up checkpoint inhibitors with immunomodulatory antifungals, such as caspofungin, for example, that alters cell wall and invites phagocytosis by immune system, then you get a synergistic effect. So in this particular work, we have found that not the oncological doses, at least in mouse models, are the right ones for infectious disease application, and then you can get synergies with immunologically active antifungals. And this also reflected to the work Tobias Hall and ourselves who have done in the past with immunological interplay of some antifungals such as caspofungin with the immune system. And then we became a little bit more ambitious and said, okay, what will happen if we give checkpoint inhibitors to a pulmonary model of mucormycosis, a disease that, as you know, there are not many drugs, and immune system is a big driver of poor responses. And in this paper that we published this year in Frontier of Immunology, we have shown that basically checkpoint inhibitors are protective alone against pulmonary mucormycosis, and some checkpoint inhibitors are better than others. Not all are created the same. In this particular context, basically PD-L1 inhibitors are better than PD-1, although both of them were quite protective. And this coincided with some emergence of reports in the literature when clinicians start using checkpoint inhibitors with gamma interferon for refractory fungal infections. The most protected and the most Lazarus effect kind of case report came in Lancet ID with nivolumab and interferon in a desperate case of traumatic mucormycosis in a normal host. When the patient was dying, they gave this combination, the patient walked out of the hospital. When this was tried in more immunosuppressed patients, one was a German report in a patient with co-infection of aspergillosis, mucormycosis, and leukemia, and another report from France that was published a couple of years ago in a patient with co-infection of aspergillosis and mucormycosis in the setting of COVID and diabetes. The immunological readouts were very, 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 very promising that this works, but it was obvious the drug was given too late, when it was a very salvage refractory case. Inviting the idea, can we use these drugs earlier in the natural history of infection after maybe an antifungal, reduction of fungal burden, and then immune point inhibitors to counteract immune exhaustion. For all these ideas, there is another dedicated talk in this afternoon. I'm not going to belabor about this, but we have become quite excited about the potential role of checkpoint inhibitors for fungal immunotherapy, which is obviously a very interesting thing to think about because those drugs are not NK cells, they're not molecular engineering T cells. The logistical burdens of the disease are not there. There is a cytokine-like approach to fungal immunotherapy. There are a lot of things to be worked out. There is a review that's going to come in the literature very soon that we talk about the nuances of checkpoint inhibitors in fungal immunotherapy. And we're trying to take this further and ask the questions, okay, in normal mice that you immunosuppress with cortisone and you give high dose of fungus, things happen, but is this the right situation? So we're moving to study the same questions in a leukemia model of aspergillosis, when we're going to give RSC plus minus checkpoint inhibitor, infect them with aspergillus, and see in this disease context setting whether checkpoint inhibitors is going to be as protective as we have seen in immunocompetent mice. It changes a little bit the line of thought. The other question that we don't talk about these new drugs is, what do we know about these new drugs' effect to antifungal immunities or to fungus by themselves? So we have published in the past, a long time ago, with Dr. Chen, who spoke before, an idea about drugs that are used in oncology that can affect the immune responses or fungal virulence. Most of the drugs come from the Kenda field. But we're interested about venetoclax, that is as popular as checkpoint inhibitors for AML. And we're trying to go to the idea, this is an anti-apoptotic agent that kind of poisons mitochondria in leukemia blast, whether this drug can have an antifungal effect. And we're in early experiments to try to explore whether the neoplastic drugs themselves affect fungal fitness without have nothing to do with drug-drug interactions with drugs, etc. Moving a little bit because of time, I'm going to talk very quickly about CAR-T therapy and NK therapy, another evolution in oncology, obviously, with ALL and refractory lymphomas. The key question here is tissue persistence. And you see new generation of CAR-T cells being introduced, and the field is moving very rapidly. We have published in the past about CAR-T cell therapy as an antifungal strategy. I'm not going to touch on this in the future at this point, but I want to make a point here that one in a blue moon, not as commonly as we think, you can see fungal superinfections following CAR-T therapy, typically in heavily pretreated patients who get a cytokine release syndrome, get steroids or IL-6 inhibitors, and have prolonged cytopenia. In this patient population, probably antifungal prophylaxis and excess fungal risk are real considerations. In this particular review of the literature, we identify the people who are at high risk for severe infections, including fungal infections following CAR-T therapies, relapsed refractory lymphoid malignancy, cytopenias, active CMV, CRS or HLH, baseline cytopenias, etc., and then most of the people will go with a mold-active prophylaxis. So if you see critically this field of new adenoplastics or biologicals and what does this mean for infectious disease in general and mycology specifically, the question is, what is the epidemiology? I think we have the early stages of capturing this, and I think mycosis study group can be a very good platform to really define epidemiology of these new drugs. Typically because there is a lot of clean data in the literature. A lot of randomized controlled studies of these drugs exclude people with active fungal infections. How mouse models can inform human data and human decision-making for fungal risk is another area. What is the best strategies to re-stratify patients on biologicals? What is the natural history of fungal infections in people who get biological infections? Can we synergize some biological like checkpoint inhibitors with immunopotentiating antifungals, such as the echinocandins? Can we see iris-like inflammatory syndromes in some people on all these biologicals? And rarely, and we have a paper that we're to publish soon, is how much these biologicals can be mimickers of fungal infections, and also how much infections can be mimickers of toxicity. So to conclude with some reflections, if you ask the question, what is my risk if I have lymphoma or CLL and I get ibrutinib, this is a complicated issue because you see issues of immunogenetic predisposition, and this is a good segue for Michalis' talk, cumulative immunosuppression, comorbidity, something we don't think about and talk about it, off-targeted effects of these biologicals, environmental exposures, side of type of underlying disease. And since we're talking about drugs, in the previous segment, we talk about how a new drug can affect outcome, including biological immune interventions. Let's not forget that this is going to be a very complicated question in opportunistic infections. I think for Cryptococcus, it's a little bit cleaner of a disease to study, but here you have the site of infection as a cause of variability, patient factor, drug characteristic, intrinsic activity, microbiological effect, PK/PDs, pre-exposure to fungi, and immune host responses. And going back to immune therapy, as you can see here, this is a very active area of investigation. Gamma interferon, GM-CSF, NK, T cells, checkpoint inhibitors, but a whole slew of strategies that are to be studied because as for Cryptococcus, there is this notion, the final fifth, the 20% of people who die of Cryptococcus. The same seems to apply for opportunistic mold disease. You have the final third. You have very good drugs that really control 2/3 of patients, but the immune, and John Perfect puts it very nicely, the host is the most. These 30% might be moved with this type of interventions. So for the new people in the field, going to mycology, especially in the area of opportunistic fungal infectious leukemia, we're in wave 4 now. Wave 4 is new biologicals, what that means, new fungal pathogens, Candauris, new syndromes like COVID-associated mucormycosis, and mycology is going to be a very exciting intellectually but niche area to study in this concept. So I'm going to finish here. Thank you for your attention.